expired. Mr. Kind is recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you for holding this very important hearing. Again, we had an excellent panel, and your testimony here today is very appreciated and quite inspirational. I mean, what I've heard you in your testimony, reading through your written submission as well, it's hard to find any inconsistency in what's happening in the private world versus what reforms are being advocated in the Affordable Care Act. And Dr. Nichols, I couldn't agree with you more. There has to be a convergence or harmony in delivery system and especially payment reform between both the private and the public spheres, or it's not going to work very well. And I'm proud that I hail from a state in Wisconsin that seems to be out ahead of the cost curve. And Dr. Lewin, I'm going to go to you shortly here to talk about the Smart Care project that you've submitted to CMMI for an update on that. But you look at certain models of care that are proving very effective, from the Mayo system to Gunnarsson to Marshfield to Aurora to Dean to Theta Care, highly integrated, coordinated, patient-focused, which provide models of where we need to drive the healthcare delivery system, and hopefully, ultimately, and I think this is going to be the verdict on any type of healthcare reform in this country, the payment reform that's desperately needed. And we've got direct control over Medicare, and I'd love to see fee-for-service die as quickly as possible so we can get to a value or quality-based reimbursement system, which sounds to me what you guys are all working on right now with the type of initiatives and the type of projects and demonstrations that you're involved in. And Dr. Lewin, I mentioned the Smart Care project in Wisconsin. You're teaming up with the Mayo system of across my hometown, but also UW Health Systems and Aurora in the state. Could you explain a little bit more what the goal is, how it's going to assist physicians, how it's going to lead to better quality outcomes for the patients, and how you see that working?
Great. Well, it really is a physician-mediated approach, and it uses really all the tools that we've developed in cardiovascular medicine to achieve a result of better outcomes, better patient care at lower costs. So a good example will be the use of the Pinnacle Registry in the outpatient setting to better and more consistently manage high blood pressure, dyslipidemia, cholesterol and so forth, anticoagulation, and heart failure, to reduce the number of heart attack admissions, strokes, and heart failure admissions. Now, this is billions of dollars nationally, billions and billions, and in Wisconsin, it's going to be a lot of money. And even with the integration of that you've got there, there's still a lot of progress that we know can be made. In addition to that, we're going to be applying the focus tool on the inpatient side as well to choose the right image. There's a bewildering array of images now. There are a dozen kinds of echo tests, a dozen kinds of nuclear tests, CT, MR, positron emission, and the science just keeps growing faster and faster. How do you choose the right test for the right patient, or does the patient even need the test? Well, staying up with that science is awfully difficult. So using the focus tool helps you with 6 clicks at the point of care make sure that you're ordering a test, or you don't need to order a test, figuring it out right away. Far better than a radiology benefit manager approach, where you're calling a number and asking for permission. They're going to apply that across Wisconsin. Also going to apply appropriate use with shared decision-making to help prepare patients who have coronary artery disease determine whether in their future, which pathway they're likely to go down: medical therapy, angioplasty and stents, or bypass surgery. Now, a lot of times people end up in the cath lab on the table, partly sedated, where, they're going to make a decision about whether they need a stent or not. That's not when you want to ask that question. You need the shared decision-making early on. You need to explain to the patient what the options are, what the complications might be of procedures. And then, if the anatomy finally says it's a gray zone, you would have prepared, the patient would have said, I'd rather go the stent in that circumstance, or I'd rather take the medical therapy. That needs to be done early. And if we do that early, a lot of people will move toward less intense care. They would try the medicine, or they would try the stent rather than the surgery. So I think applying all these tools across the board, and then using the registries, both inpatient and outpatient, to give the hospitals, the medical groups, feedback on their performance.
Dr. Lewin, I love your phrase, bringing science to the point of care. Another way of saying it is, let's find out what works and what doesn't, and drive that information into the hands of our providers and patients through a shared decision-making. So I don't know why there's all this angst and concern about comparative effectiveness research. That seems to be the whole point of driving science into the the point of care and into the hands who need it the most. And
Yeah.
Dr. Sandy, this sounds very consistent with what United Health has been doing with imaging services and trying to use clinical studies and support tools for physicians in order to deal with it. We may not have time this round to get your response, but I'd like to follow up a little bit more on what United Health has done in that area too. Thank you, Mr. Chairman.
Thank you. Mr. Reichert from Washington, recognized for 5.